Dear all, welcome to this new webinar of this series and supported by EUROGEN, OMNI-NET, International Federation of Spina Bifida, and today by ERKNet. I'm Giovanni Mosiello speaking, and welcome to all again, and nice to have you with us. And Dr. Zymak, please.
Вітаю, шановні колеги! Раді чути і бачити вас на черговому вебінарі із серії вебінарів, присвячених спінальним дисрафізмам. Як ви пригадуєте, ці вебінари організовані спільно з Європейською референсною мережею з рідкісних урогенітальних захворювань ERKNet, Міжнародним благодійним фондом OMNI-мережа для дітей та Асоціацією Spina Bifida та Hydrocephalus. Сьогодні ми розпочинаємо 8-й із серії вебінарів, і він присвячений саме оцінюванню функції нирок у дітей з спінальними дисрафізмами. Професор Mosiello.
Yes, thank you very much to all to be there. And today the topic will be on the kidney function in children with Spina Bifida and myelomeningocele. And in the past webinar, we had the presentation about the first line management of these children that include clean intermittent catheterization and anticholinergics. So we would like to resume the answer to the question that we received. And the first one was related to the best way to determine the time interval between catheterization. Of course, we have to consider age, bladder capacity, fluid intake, renal function, and the underlying pathology. So we can suggest a standard that, of course, is related to the bladder function that changes during the time. And of course, a newborn in neonates, more catheterization will be required, so 6 catheterization per day are suggested. Of course, we can decrease after the first year of age. Of course, if there is a nighttime polyuria, an underwhelming catheter during the night should be considered because it could be very useful. And the other question that we received was related about the recommended medication to prescribe it before urodynamics. We discussed during the presentation our Professor Reinemann about the use of anticholinergic, what to do, to stop or not. It depends about the indication of the evaluation urodynamic. And of course, we have to consider the risk of UTI, so antibiotics prophylaxis is strongly suggested. And you have to remember that UTI is a contraindication for urodynamics. Of course, we have also what we are learning in the previous webinar, that the UTI is different from bacteriuria. What about the timing of consumed fluid during the day regarding the catheterization? Of course, we have to consider the volume and the timing that must be considered, especially in the children, in fragile children that are in enteral or parenteral nutrition, that commonly is performed during the night. Other points to consider are the bladder capacity expected for age, or a real bladder capacity, if you know, evaluated by urodynamics, as well as the renal function, that means polyuria. Other question that we have received and was about the percentage of children requiring surgery. We have to remember that at the birth, the majority of these children have normal kidney, normal bladder. Then there is the risk during the time for a wrong or missing management. So in a correct management, the majority of patients could avoid surgery with a correct, prompt, proactive management. That means to start yearly clean intermittent catheterization and anticholinergic. What about the management of severe complete urinary incontinence? This is due to pure bladder outlet resistance And we know that we have a different solution, more or less invasive. We can use bulking agents with all the limits that we know. We can use sling, fascia sling, homologous sling, or heterologous. We can perform a different kind of surgery for bladder neck reconstruction. We can use artificial sphincter. Solution must be evaluated to consider also the individual status of the patient, is of their motivation. And it's very important to consider the secondary change that occurs in the bladder function due to the increased bladder outlet resistance. That means that induces the risk for upper urinary tract due to increasing pressure inside the bladder, and also the risk for a secondary vesico-urethral reflux. Other question, very interesting question, was related to the different catheter to use in a stoma, in a bleeding stoma. What kind of catheter to use? Uncoated catheter must be used for continuous bladder drainage. That means for endovascular catheter during the night when required, or for improved healing after bleeding. So in a bleeding stoma, we have to use uncoated catheter as a Foley catheter. Coated catheter that are best catheter, of course, for a clean internal catheterization must be used only for a clean internal catheterization. So that means that need to be removed after the bladder emptying. The last question that we received was about the use of combination of antimuscarinics or cannabinoids. As a general rule, it's always better to try to avoid multiple therapy, either for the cost or either for the reduce the risk of side effects. For NDO, the first choice is always to use oxybutynin for neurogenic detrusor activity. Other drugs exist, of course, and some are available in our countries, other one only in specific countries, single country, and tolterodine, solifenacin, fetotiridine, trospium, chloride, propivarin, all could be useful, and no one is without side effects. And for these, you have to consider also that before to switch it from an anticholinergic to another one, maybe could be useful to consider as peroxybutynin intravesical administration. Other option that you can consider is the mirabegron. Other option is available is a water-bottling toxin A injected into the blood. The question regarding cannabinoids, and there are no experience of pediatric patients with spina bifida. Cannabinoids are mainly used and in adult patients, of course, and the usefulness has been tried. There is a use in cerebral palsy patients. There, in these cases, could be useful also to treat all the contracture of the spasticity of the patient. Anyway, we don't have evidence-based medicine data with the use of cannabinoids in the spina bifida children. Thank you very much. And now I believe that we can move. I don't know, Dr. Zymak, if you have any comments about that.
Thank you very much, Professor Mosiello. Дякую професору Мосієло за коротке узагальнення відповідей до попереднього вебінару. І нагадую, що перечитати ці відповіді ви можете також на сайті ERKNet. Хочу також нагадати декілька організаційних питань. Кожен, хто відвідує наш вебінар онлайн, отримає сертифікат участі. Учасники також мають можливість отримати і 1 бал міжнародної акредитації, якщо вони заповнять опитування після закінчення вебінару. Також специфічне оголошення для української аудиторії. Все-таки у разі повітряної тривоги просимо вас негайно перейти в укриття. Перегляд запису вебінару та відповіді на питання будуть доступні згодом. А зараз я маю честь передати слово професору Мосієло для представлення нашого сьогоднішнього спікера, професора Міхала Матерніка.
Well, thank you, Dr. Zymak. It's a great pleasure for me to have with us today Professor Michal Maternik. Professor Michal Maternik is senior consultant in Gdansk. in pediatrician and in pediatric nephrology, and he is member of the European Rare Kidney Disease ERKNet consortium in the European Reference Network. And first of all, he is one of the founders of the International Children Continence Society, where he is a board member for many years. And I believe that his point of view will be very useful because he is a nephrologist, pediatric nephrologist, with a great expertise of more than 30 years on the management of these severe and complicated cases where there is to manage either to preserve the renal function and either to manage continence. Dr. Zymak, please.
Що ж, професор Michal Maternik, the floor is yours. Welcome.
Good evening to everyone. I'm very happy to see you, and I warmly invite you for our presentation and our webinar. And with pleasure, we answer all questions afterwards.
Good evening, dear colleagues. My name is Michal Maternik. I'm a pediatric nephrologist from Medical University of Gdansk in Poland, and I would like to thank for the kind invitation to give this talk about the kidney function in children with myelomeningocele during our EU-Ukraine webinar series on spinal dysraphism. This presentation was prepared together with Professor Giovanni Mosiello from Department of Pediatric Nephrology in Milano. As all we know, kidney function is evaluated according to eGFR, which is defined as a volume of fluid filtrated from renal glomerular capillaries in the Bowman capsule of the kidney per unit of time. Normal values should be over 90 milliliters per minute per normalized body surface area. Chronic kidney disease is defined by the time of kidney function loss, which should be longer than 3 months, decrease of GFR, and additional abnormalities like albuminuria or imaging abnormalities as a markers of kidney damage. These imaging abnormalities may be recognized by ultrasound, VCUG, CT, MRI, or isotope scans. Among them, most typical findings in children with Spina Bifida with neurogenic bladder are hydronephrosis, renal scarring, vesicular reflux, or small echogenic kidneys. As you can see on the right side, chronic kidney disease is divided for 5 stages, beginning from stage 1 with normal GFR, but other findings, through the stage 2, stage 3A, B, stage 4, with continuous decrease of GFR, to the stage 5, what we call end-stage renal disease or kidney failure, where the renal replacement therapy is needed. Decrease of GFR and development of CKD is related to some metabolic complications like hyperparathyroidism, anemia, acidosis, hyperkalemia, or hyperphosphatemia. They are present since the beginning of decrease of GFR. Of course, incidence and severity of this complication increase with GFR loss, as you can see on the graph, but all of this need to be recognized as early as possible and should be treated properly, because untreated may lead to the life-threatening situations. If we are talking about the kidney function, we use eGFR, which means estimated glomerular filtration rate. It can be calculated using creatinine or cystatin C level. Additional factors which are taken in account during calculation of eGFR are sex and height of the patient. eGFR, as I said, supposed to be over 90 milliliters per minute per normalized body surface area after the first year of life. The first thing is the proper evaluation of GFR. Usually, in daily practice, we use bedside Schwartz formula, which take into account only height and serum creatinine level. But unfortunately, this formula is not perfect for the patient with Spina Bifida due to the smaller muscle mass, what influence creatinine level, but also second parameter, as height is sometimes difficult to obtain, especially in children on wheelchair or with vertebral column scoliosis. All of this may lead to the overestimation of eGFR, so other formulation using creatinine and cystatin C, for example, Schwartz CKD under 25 formula, or Zapatelli formula specific for Spina Bifida patients may be better to reflect true kidney function in this vulnerable group of patients. It is believed that the children with MMC are born with the normal healthy kidney. But according to our recent study in Gdansk, among 60 children born with MMC, we have found quite different picture. At the initial evaluation and the third month of life, we recognize that the one child has already decreased creatinine level. 26% of them got a hydronephrosis. We find out the bladder wall thickness in ultrasound was seen in 28% of patients, and vesicular reflex was present in 23% of patients. Although all these children had introduced CAC since the first day of life, it means that about 25% of children born with MMC are at risk of development of CKD since the birth. Proper evaluation of the kidney function is crucial, and there is a question: how often this patient develops chronic kidney disease and end-stage renal disease? In large American cohort with more than 1,000 patients observed for almost 18 years since birth, 0.3% develop end-stage renal disease at the age of 20 and 2.1% at the age of 30. It means they need renal replacement therapy with chemodialysis or peritoneal dialysis to reach kidney transplantation. Fortunately, it's not great numbers. However, the risk of end-stage renal disease in this group of patients is 100 times higher comparing general population. But end-stage renal disease is the fatal end of journey through the chronic kidney disease. If we look in details in the cohort of more than 100 Turkish patients with MMC, we can notice that 40% of them have signs of chronic kidney disease, and 10% of them have eGFR below 60 milliliters per minute, which represents stage 3 or higher of chronic kidney disease. In this study, eGFR was evaluated with bedside Schwartz formula, so probably underestimate the presence of CKD. Even high numbers of chronic kidney disease we recognize in our group of patients who were transmitted to the adult care when we evaluate the eGFR using cystatin C. 60% of our patients have some degree of kidney damage. Fortunately, majority of them without or only with a mild eGFR decrease, which means that chronic kidney disease incidence increase with time in this group of patients. So why it's happened? Why we can see the CKD development in a great proportion of patients with CAC, and what is most important, what we can do to prevent that. Of course, using folic acid before conception to avoid MMC, it's one option, but for our patients who are already born, it's not an option. So what we can do after birth? Definitely, we need to prevent dysfunctional bladder outlet obstruction, but also we need to prevent other risk factors which leads to development of CKD, like urinary tract infection, vesicular reflux, kidney scarring, and also additional factors of CKD development like hypertension, obesity, and nephrolithiasis. Truly sad, unfortunately, we are not really good in prevention of these factors. For example, as you can see on the graph, only 20% of children with MMC avoid single episode of pyelonephritis till adulthood. So it means 80% of them have a risk of development of renal scarring. If you look at prevention of VUR, we are not also very successful. Only 40% of these children will not have VUR till adulthood, according to presented data. The same situation is with the renal scarring. When there is a UTI or there is a vesicular reflux, especially together, we can observe renal scarring is present in about 80% of children with MMC, at least on the one side. So it means it is additional risk factor for development CKD, but also of development of hypertension, which influence kidney function. So what we can do? At first, the prevention of bladder outlet obstruction and presence of increased pressure in the urinary tract should be done immediately since the birth. According to EU pediatric urology guidelines, proactive management with CAC should be introduced to all children with Spina Bifida since birth. As you can see, this active management leads to decrease of number of renal scarring, but also what is very important, it's easier for caregivers to cope with the procedure, especially regarding the fact that the vast majority of children will need this lifelong. How important is influence of urinary tract infection on kidney function shows in this study. Among 400 Chinese children with MMC, there was found that after 4th pyelonephritis, 30% of them have decreased GFR. And after 8th pyelonephritis, 100% of these children have decreased GFR, what means they develop chronic kidney disease stage 2 or higher. Another topic regarding prevention of kidney scarring is urinary tract infection prophylaxis in all children on CAC. Data regarding this topic are quite conflicting. On the one hand, there is data that constant prophylaxis decrease number of UTI episodes. Constant, it means every day, very strict administration of the prophylaxis. On the other hand, the prophylaxis definitely increase bacterial resistance for antibiotics, which is very dangerous in long-term run and may lead to the increase of rate of hospitalization of this patient due to the infection caused by multi-drug resistant bacteria, which probably is also a problem in Ukraine. Another way to UTI prevention is introduction of CIC. There is a clear negative correlation between CIC and UTI after 12 months since introduction of CIC, as you can see on the graph. So there is a significant decrease of pyelonephritis rate comparing to the time before CIC introduction. Even if there is no antibiotic prophylaxis, we can see this effect. This effect is not seen after first 6 months of CIC introduction, probably due to the learning curve of the caregivers. But also, early introduction of CIC not only prevents UTI, but also decrease in VUR grade. So which is also important to prevent kidney function and to prevent chronic kidney disease. UTI are also important and underestimated issue for patients and caregivers of children with Spina Bifida, according to the surveys. Parents claim that they are unprepared for morbidity associated with infection, and also they complain about the lack of knowledge and need for education in non-specialist healthcare providers. What is also important to them is to have a chance to contact pediatric nephrologists or pediatric urologists to avoid over-recognition and over-treatment of urinary tract infections. It is very important also to prevent kidney function to incorporate child in CIC regime as early as possible. Usually in our center is about 7 years of life. But we need to remember that 1 of 5 child will never take over responsibility on CIC. And additionally, from the parent and caregiver perspective, there are some barriers regarding CIC, like technical difficulties, problem with access to the catheterization supplies, and training others than parents to CIC, which mainly influence the school time, where if the patient cannot catheterize by themselves, they stay without catheterization for several hours, which influence the kidney function. All these elements leads to decrease in compliance with CIC, as well as difficult time for teenagehood. And all this may lead to development of CKD and later age due to the hostile bladder. Obesity is another issue which may lead to the hypertension and chronic kidney disease. And if you look for the population of children with MMC, almost half of them suffer from overweight and obesity, as you can see on the left side graph. It was shown in recent study that simple diet intervention is efficient to weight loss in these children and should be promoted among the parents and patients. It's not only important regarding the hypertension, but also regarding self-mobilization of the patient and well-being of the caregivers. Obesity is also an important factor which may negatively influence self-catheterization and creation of the stomach for the catheterization. So it's very important to prevent and treat obesity in this group of patients due to the different reasons. As it was mentioned previously, another risk factor for CKD development is the hypertension. As you can see on the graph of the left side, the hypertension incidence in children with MMC is higher in general population in every age. As it was shown, the renal scarring due to the urinary tract infection is the main factor which leads to development of the hypertension in this group of patients. Although non-pharmacological treatment like reduced salt intake, healthy diet, weight loss, exercise, they are very important in treatment of hypertension. It's very difficult to introduce in this group of patients. So usually we need to use drugs to control blood pressure, and usually we use ACE inhibitors and angiotensin receptor blockers due to the fact that most of these children have renin-dependent hypertension. And also we know these drugs are cardioprotective and nephroprotective, so we've got the additional values for these patients. Another risk factor for development of the chronic kidney disease is nephrolithiasis, which we know it may influence the kidney function. And main risk factor for nephrolithiasis are immobilization, urinary tract infection, but also metabolic complications seen in chronic kidney disease, mainly acidosis and hyperparathyroidism. Another group of patients are patients after bladder augmentation, who are in the main risk of the development of kidney and bladder stones. As you can see on this graph, around 25% children after bladder augmentation develop kidney and bladder stones in the period of 25 years. And we need to be aware that nephrolithiasis incidence is 10 times higher after renal bladder augmentation comparing to general population. And what should be done? It should, in prophylaxis for renal stones, should be introduced immediately, like proper fluid intake, irrigations of augmented bladder, a low salt diet, which also prevents nephrolithiasis. But if the patient reached the end-stage renal disease and need the transplantation, it's very important to encourage them. This group of patients got completely the same rate of graft survival comparing to the other patients with congenital urinary tract malformation. So fact that the patient have MMC should not be recognized as a contraindication for kidney transplantation. However, special attention should be put on bladder function, and usually main bladder surgeries like augmentation or vesicostomy or Bricker procedure need to be performed before or during transplantation procedure to be sure that the bladder is safe for the transplanted kidney. So, finalizing my talk, I would like to encourage that standard formulation based on creatinine may overestimate eGFR, so we should use other formulations for better evaluation of kidney function. We need to remember the CKD, so chronic kidney disease in children with neurogenic bladder due to the Spina Bifida, is quite common, and prevention of vesicoureteral reflux, urinary tract infection, hypertension, prevention of obesity, and nephrolithiasis is crucial for kidney function preservation. And what is very important, CIC with child involvement played very important role in prevention of chronic kidney disease. Once again, thank you for your attention. And in this occasion, I would like to share pictures of the patient who on renal replacement therapy from Ukraine, who were successfully transferred from Ukraine to Poland at the beginning of the war with the great help of Dr. Roman Andrunevich, who is pediatric nephrologist for Western Ukraine Specialized Pediatric Medical Center in Lviv, and all together we can save their life. So I hope so. This initiative with these seminars also improve health care for MMC patients in Ukraine. Thank you very much for your attention.
Dear Michael, thank you very much for your very, very interesting presentation and very complete. And I believe that we have a fruitful discussion and with your experience. And I would like to remember that if you wish to ask a question regarding the presentation, you can do so by typing it into the question box. And some of the questions will be addressed in the webinar. We have just received some questions before. And anyway, you can also submit questions after the webinar, and these will be answered at the beginning of the next session as usual. Otherwise, it will be also published on the eUROGEN website.
Thank you very much, Professor Maternik, for sharing your experience and expertise. And our special thanks for helping Ukrainian children. And now I see several questions.
Yes.
Dear colleagues, please give our comments.
Yes, thank you, Dr. Zymak. And I totally agree with you. I present my compliments to Michal Maternik to be able to remember us to that webinars are important, but it is important also to take care of the children crossing the border, and with the hope that to have Ukraine as soon as possible in the European Union with us. And we received some questions, and the first question is a severe question. What indicators of kidney function are indication for kidney removal? So, what is your opinion, Michael?
It's always like in medicine, it depends. Because if it is non-functioning kidney, but if there is no reflux or hydronephrosis in this kidney, and this kidney do not cause any problems like hypertension, I would not decide to remove that kind of kidney only because it's unfunctioning. But if there is a kidney which make a trouble, like we've got the recurrent pyelonephritis due to the reflux to this kidney, or we've got the hypertension, I think if GFR split function evaluated using, for example, scintigraphy, it's below 10%, I would discuss to remove this kidney because we know that hypertension or recurrent pyelonephritis may lead to the damage on the other kidney. So we need to prevent the function. So it depends on the situation. It's not a strict values when below which we need to remove the kidney.
I totally agree with you, Michael. And only one point to stress that if you have to remove the kidney, please consider to remove only the kidney and not the ureter, because ureter could be useful for derivation, because in some cases could be used for Mitrofanov procedure instead of the appendix, if the appendix is too fine or it has been removed before. And the same, if there is a large ureter, in some cases could be used for augmentation of the bladder. And the second question is from your own practice, which method is better? You presented during presentation, but maybe it's better to stress again for determining the glomerular filtration rate, and Schwartz formula or formula using creatinine or cystatin C. If you can choose between one of these and you are rich, what do you prefer? Cystatin C or
In fact, in daily practice, we use cystatin C formulation together with creatine. So CKD under 25. And additionally, we calculate GFR only based on the cystatin C. We try to avoid using the short formula, which is, in my opinion, insufficient and overestimate GFR in children with myelomeningocele.
Again, with you, of course, and do you have a suggestion regarding the parameters that in my experience, I see that especially with the wheelchair children and parents missing to take the weight and the age of the children. And do you have some suggestion for this?
Once again, the missing. So we measure the patient and take the weight of the patient during the outpatient visits, and we use special stadiometers for that, for children who are in sitting position, and in that way we taking height of this patient, because also it's necessary to evaluate their development in this way also. And as I show you, most of them, half of them suffer from overweight and obesity. So it's very important to monitor the weight and height of these patients. Again, during the outpatient visit, every time we measure the blood pressure, which again is very often elevated, especially in children with renal scarring. So all these measurements should be taken routinely at every visit, at least.
Thank you. And in one question by me, and in a child without chronic renal failure, with a normal renal function, and how many times per year do you suggest to measure the weight, to measure the creatinine or cystatin C, and to the blood pressure?
Usually,
once a month.
No, we usually see this patient once a year.
Okay.
But in younger children up to age of 5, we want to see them more often. Let's say 4 times in the first 2 years of life, and then half yearly till the age of 5. And then if there is nothing happening, like the patient do not have recurrent urinary tract infection or hypertension, obesity, we see them once a year as a nephrologist.
Okay, so your suggestion that in infants until the 3-4 years of age is better to check 4 times per year, and then to reduce every 6 months, and then I'll check a control once per year. Thank you very much, because I believe that is a practical recommendation, very useful. And there is one question about the arterial hypertension that is a significant risk factor for the development of chronic kidney disease in children. And what can you report your experience about the percentage of patients that receive pharmacological correction or hypertension, and which resistance do you meet in your practice?
So answering for this question is tricky, because another percentage is in the younger children and another percentage is in the older children, and we can observe there is an increased rate of hypertension with the age, and for that the influence is it is influenced by weight of the patients and also of the renal scarring. So I would say up to 10% of our patients need to be treated with the pharmacological treatment. And no, we do not observe resistance for the treatment among the parents and patients, because we try to explain them how important is the good control of blood pressure. And it's in the long run, how it influences the kidney function, but also the heart, the brain. So if we prescribe the drugs, they usually take them. But it's important to use long-acting drugs, because usually if we prescribe the drug which should be taken once a day, there is better compliance comparing to drugs when you need to take twice or 3 times a day.
Thank you very much. And in my experience as a urologist, one of the big concerns with children growing up, with adolescents, is adherence to treatment. We have a concern with the clean intermittent catheterization and also with anticholinergic. In your experience, do you met the same concern with hypertension treatment?
Definitely yes, and I find the teenagehood period is the most difficult one, because, and we can see that in every patient, not only with MMC, but also patient, for example, after transplantation, some of them do not take drugs, immunosuppressive drugs. So this close monitoring and cooperation with them, it's very important is in this difficult time. So sometimes we want to see them more often than once a year if they need hypertension treatment, or if they need other treatment just to support them. But also it's observed that just after adolescent period, we can observe tremendous increase in development of end-stage renal disease between the age of 18 and the age of 30, because in my opinion, the patient have more closer care in pediatric units comparing to adult units, and we've got abilities to observe them more often and take care about them more closer. So it's very important in this period of transmission to clarify everything to the patient, that he can understand that continuous CAC, continuous antihypertensive therapy, and so on is very important for their kidneys, for their life.
Thanks. I totally agree. And the transition process is a concern everywhere, because in some cases we have also patients that miss the clinic where they have been referred, because they don't found the same family that they grow up, that the urotherapist, the nurse, the doctor, the change of the team sometimes is dramatic. And one question about always the management of long term, and after the transition and before the transition process, do you have a contact with adult colleagues, with adult clinic, and for how long do you manage together and before to leave the adult patient to the adult clinic?
So in my country, there is quite a strict moment, because at the age of 18, there is no more allowed for pediatrician to take care about the patient. So we need to transfer them to the adult care, but we've got the clinical meetings, and depending on the or about the needs of the patient, or we transfer him to the urological service or nephrological and urological service. It's always depends, but we try to send them to the dedicated doctors who are with touch with us.
One question about the use of alpha blocker in this patient that could be useful for bladder emptying in some cases, and also for hypertension control. What is your experience? Do you like to use or not?
In fact, there, as far as I remember, was only one randomized controlled trial with alpha blockers in children with myelomeningocele, and it wasn't show any difference in bladder function and any difference in leak point pressure in these patients. So I'm not great fan of these drugs. And in treatment of hypertension, usually we start with ACE inhibitors whenever it's possible, and then add calcium channel blockers. So probably alpha blocker will be our third or fourth choice. So that's fine. But sometimes we use them also.
Okay, thank you. And one question about the relationship between, there is any connection between Spina Bifida, myelomeningocele, and diabetes mellitus in your experience?
It depends. We haven't observed this connection with diabetes mellitus stage type 1, but if there is prolonged obesity and patient develop obesity and hypertension, with time he can develop diabetes mellitus type 2, which is adult type. So sometimes we can see that, but with the type 1, we cannot see any connection, and I'm not aware about studies where the diabetes mellitus is more often in children with myelomeningocele comparing to the other children.
Okay, so thanks. And one question or two is polyuria is always quite common, related either to the renal failure, that to the diabetes mellitus, and on the other side there is the risk for this patient to solve the continence concern, reducing the fluid intake. And what do you recommend to your patient as a fluid intake for the day? And do we have a specific...
As a nephrologist, I'm totally against the decreasing amount of fluid. Because it leads to the dehydration, it promotes nephrocalcinosis. That's the two main points. And polyuria, it's really not very often seen in children with even mild decrease of GFR, because the concentration possibility of the kidneys decrease pretty low in development, pretty late in development of chronic kidney disease. So I would suggest rather normal fluid intake as for other children. I know there is some practices the children decrease fluid intake, or parents decrease fluid intake in these children due to the wetting problems, or to avoid or decrease number of catheterization. But in my point of view, it's makes no sense and leads to the worsening kidney function and other complications. So definitely there should be we should use as much water as in normal children.
No, I totally agree. Thank you for stressing this concept. And I will last point for discussion is thanks for stressing the role of obesity of this patient. It is an high risk. And do you think that we can do something more to increase the sport activity in these patients?
Definitely. What I observe, if the patient are engaged in professional sport club, and I've got several patients who doing athletics, for example. It's very engaging, these children, and they've got a lot of fun with that, and we should promote any kind of sport activities among the children. I've got 2 or 3 of my patients who play rugby on the wheelchair, which is also very incorporating them, and they're very glad. So I think, and more there are more and more places for disabled children to practice sport, and should be very promoted.
Michael, thank you very much. And Dr. Zymak, I don't know if you have some question more.
I'd like to say thank you, Dr. Maternik and Dr. Mosiello, Professor Mosiello, for your such active and very informative discussions. До наших українських колег, як ми зрозуміли, що проблеми, з якими штовхуються пацієнти, вони є доволі загальними і спільними. Безумовно, що підлітковий вік – це завжди виклик для будь-якого лікування і до зниження комплаєнсу до лікування у таких пацієнтів. Дякуємо за нотатки стосовно вживання рідини при поліурії і дуже важливі питання менеджменту ожиріння. Мабуть, ці питання ми досить плавно перейдемо до наступного вебінару, на якому ми плануємо обговорити питання, ключові моменти підходів до реабілітації таких пацієнтів і, можливо, проговорити так само питання і про фізичні навантаження у пацієнтів із спінальними дисрафізмами. Once more, thank you very much for all our participants and our understanding speakers and moderators. And especially thanks to Dr. Shihan for your technical support and organizations. I'm sorry. І передаю слово професору Мосієло. Професор Мосієло.
Yes, and Professor Maternik, dear Michael, thank you very much for your fantastic presentation, very clear, and also thanks for your practical suggestions. And we remember that everyone who attends to the live webinar will receive a certificate of attendance. 1 hour after the finish time, you will receive a survey to complete. And with this, you could also receive 1 CME credits. And thanks to all participants. And we have a last webinar in April. And please don't miss it. And thanks again to OMNI-NET, International Federation of Spina Bifida, EUROGEN, and ERKNet for this support. The next webinar will be the 18th of April with Dr. Jessica Della Bella on physical rehabilitation point to know. This one will be the last webinar of this series. But unfortunately for you, we will come back the next year with another series of webinars. And we received a lot of suggestions by you. And if someone would like to send other suggestions, please, you have still time. We are going to organize an extra webinar in May to present the next series. And thanks to all again. And Dr. Zymak, please.
Я також хочу приєднатись до подяк і одночасно зробити ще презентацію наступного вебінару, який проведе доктор Джесіка Деля Белла. І саме тоді ми поговоримо про те, що потрібно обов'язково знати про фізичну реабілітацію. Цей вебінар буде останнім із серії наших вебінарів і відбудеться він 18 квітня. Але хочу зауважити, що професор Мосієло оголосив про нову програму вебінарів, яка стартуватиме восени 2024 року. Деталі слідкуйте, будь ласка, деталі будуть згодом.
Okay, thank you to all. See you. Bye.
Дякую за увагу. До зустрічі на наступному вебінарі. До побачення.